and scientific session. The last one is. For that, I would like to invite our chairperson on the stage, Dr. Suresh Mishra, Associate Professor in Department of Urology, Eminent Medical College, Prayagraj. Dr. Santosh Maurya, Assistant Professor in Nephrology Department, Eminent Medical College, Prayagraj. And Dr. Amrita Agrahari, Senior Gynecologist and Vice Chairperson, Women Doctors Wing, Prayagraj. I request our chairperson to introduce to our speaker of this session, Dr. Arun Kumar.
I would like to invite the next speaker of the session, Professor Arun Kumar, Associate Professor, Department of Nephrology, AIMS, New Delhi. Dr. Arun Kumar sir has got several achievements to his credit. He is the junior editor of Journal of Nephrology, national representative, member Youth Nephrologist Committee, and assistant editor, Indian Journal of Organ Transplantation. So will be delivering his lecture on clinical management of UTI.
The kind introduction. At the outset, I would like to thank the organizers for having me here today and keeping in line with the wonderful set of topics which are of practical management. I would be speaking about clinical management of urinary tract infections from an outpatient department perspective. So overall, UTIs are the most common infections which are being treated in the outpatient department, and I don't think we are going to have an issue with that. We'll be seeing about when do we suspect, how do we evaluate urinary tract infections, what are the general management guidelines, and some special scenarios based upon cases to help us understand how we should manage these patients better. So overall, urinary tract infection, it includes the entire spectrum of infectious syndromes which affects the urinary tract anywhere from the urethra to the kidneys. And it has been described for the last few centuries, and the initial description of sending forth heat from the bladder, which was there in written papyrus in as early as 1515 BC, signifying that dysuria is one of the most common symptoms and the most important symptoms of urinary tract infections. The reason why we are concerned about it is that there is a lifetime incidence of around 50 to 60% worldwide, especially affecting women. And out of this, nearly 50% will have a recurrent infection in the next 6 months. And in India, data has shown that nearly 40% of all women and 12% of all men, they suffer from urinary tract infection at least once in their lifetime. So that is the reason why we are always concerned about urinary tract infections. So regarding the classification, based upon the site, they are divided into lower tract infections, that is anything except the kidneys. So cystitis, bladder is involved, prostatitis, prostate is involved, urethritis when the urethra is involved is there. And it can be an upper tract infection wherein the renal pelvis can be involved, pyelitis, or the kidneys per se can be involved, pyelonephritis. And based upon the complicated nature, it is uncomplicated UTI if there is a normal structural urinary tract. And if at all there is an anatomical or a physiological abnormality, then we call it as a complicated UTIs. So with regard to how do we get UTIs, the first reason would be the ascending route, wherein due to the colonization from the periurethral area, urinary tract infections occur. And the risk is increased in females because of the lesser anal urethral distance. And you have a bowel source in both genders, whereas a vaginal source in females. And the gram-negative organisms are the most common cause, with uropathogenic E. coli accounting for nearly 75 to 90% of all outpatient urinary tract infections. With regarding pathogenesis, normally the UPEC, the urinary pathogenic E. coli, they usually penetrate into the superficial bladder cells, and then they get internalized where they form the intracellular bacterial complexes. And then they get detached and then go to the epithelial side where they call the bladder denudation. And by causing bladder denudation, they cause infiltration of leukocytes, following which they can ascend up to the kidneys and cause pyelonephritis also. The risk factors being in the children, it is usually when it is a dysfunctional voiding syndrome is there, or if there is a vasochorotic reflex. In males, it is usually because of structural abnormalities. Otherwise, it is very less common in males because of the longer length of the urethra. In females, pre-menopausal, it is usually because of sexual activity and features regarding to it, and also family history. Whereas in post-menopausal, it is usually because of incontinence and atrophic vaginitis. Overall, structural abnormalities, comorbidities, and immunosuppression, they tend to predispose patients to urinary tract infections. So going on to specific risk factors, in premenopausal women, the most important risk factor is sexual intercourse. And if at all a spermicide is used, the risk is doubled. This is because the spermicide tends to affect the lactobacilli, which maintains the vaginal pH, and therefore it causes infections. And data has shown that various types of undergarments being used, the frequency of voiding, vaginal douching, or use of tampons, which are usually questioned, they do not increase the risk of urinary tract infection. So we don't have to be worried about it overall. The second type of infection would be the hematogenous route, wherein the foci of infection is present elsewhere in the body, and then the kidneys get secondarily affected. Most commonly, this is because of staph, candida, salmonella, and mycobacterium tuberculosis. What happens is that normally we have a number of defense mechanisms which prevents urinary tract infection. Among these, the most important would be the free flow of urine. So because of the free flow of urine, normally the bacteria or the microorganisms cannot have a proper stay. When this is affected, patients tend to develop UTIs, and that is a premise which complicated UTI has. The second reason being urinary microbiome, that is the normal organisms which are present in the urinary tract, namely the coagulase negative staph, the viridans streptococci, and the corynebacterium. They usually prevent the infections by the external organisms. When this urinary microbiome is affected, either because of antibiotics, atrophic vaginitis, or other causes, the risk of urinary tract infection increases again. The third important reason being uromodulin or Tam-Ostwald's protein, which is a normal component of urine. It binds to the fimbrial proteins in the E. coli and prevents urinary infections to happen. So whenever these factors are affected, the risk of urinary tract infection increases. Our understanding of the differences is also changing over the years. Like right now, there is some data which shows that the alpha interconnected cells, which are present in the collecting duct, they are important for urinary acidification, but they also play a role in prevention of UTI. So this is something which is an evolving topic, and we are going to see much in the years to come. The first case would be what we'll be discussing, the clinical scenarios would be a young female, a 27-year-old female, who presents with a burning sensation and a discomfort in her lower abdomen. She has had a similar history for which she was treated as a UTI. She has had a normal menstrual period and she has no other issues. I would like to have a show of hands if possible. So what would you do? Would you plan a urine analysis? Would you give ciprofloxacin for a week, nitrofurantoin for 5 days, or just give symptomatic treatment and wait for the urine analysis? How many of you would want to treat the patient? If I can have a show of hands, it will be interesting. I think, yes. So once we are treating, the question would be that whether it is going to be nitrofurantoin or ciproflox. So for this, first we'll understand what is this urinary tract infection. So we have already seen about lower urinary tract, upper urinary tract, and complicated UTIs. In cystitis, we are going to have only voiding issues, and suprapubic pain is going to be there. If there is an acute dysuria, it is usually going to be urethritis. If there is fever and chills, it is usually pyelonephritis and not cystitis in most of the earlier cases. This patient usually has some symptoms of something like cystitis alone. So in cystitis, in the presence of symptoms, and if the patient has had a prior history also, investigation is not required for all patients. Empirical therapy can be given for these patients, and this patient fits into this category. The next question would be that if we are not evaluating this patient, for which patients should we do urinary tract evaluation, or should we do urine analysis? So if the patient is going to have a systemic illness or upper urinary tract disease, has an atypical symptoms like in vaginitis, has a risk of developing complications like patient is on immunosuppressive therapy or is pregnant, if is at risk of developing infection with multi-drug resistant organisms like patient has received antibiotic therapy earlier, and if the patient does not respond to empirical therapy, then only a urine analysis is indicated in patients with cystitis. The most common test being urine microscopy and a dipstick. A combination of leukocyte esterase and nitrate positivity has a very high sensitivity, and if we add a pyuria of more than 10 cells, the sensitivity is nearly 100%. So this is more than sufficient for us to diagnose urinary tract infection in most cases, but remember that the specificity is low and we may have false positive cases also. The problem is enterococci and pseudomonas will not be detected with this test, and most of the times pyridium is usually given as a urine analgesic. That can cause a false positive nitrate test. By doing this, we may have a false positive test that has to be remembered, and leukocyturia can happen in other cases also. The second thing would be a urine culture. So the diagnostic for urinary tract infection is symptoms along with a significant growth. So what is significant? So if it is a suprapubic aspiration, any organism, if it is a standard clean catch midstream urine, 10^5 should be present. Leukocyturia is not essential. That is, a culture positivity is sufficient per se with symptoms for diagnosis. We don't need pyuria to be present for a diagnosis of UTI. So a urine analysis, a midstream sample has to be collected, and we have to advise the patient how it has to be collected, cleaning from front to back, and having a proper midstream collection is essential for a proper diagnosis. Even from a Foley's collection, Foley's catheter, we'll have to wipe sterilium very cleanly, and we'll have to aspirate directly from the Foley's, directly from the patient and not from the bag. That is one way where we'll have to diagnose better for those who in long-standing catheters and also in hospitalized patients. There are a number of newer drugs which are coming up, including point-of-care tests, including paper-based assays and Maltidorf, which are still in research stages. For all practical purposes right now, routine urine analysis and culture are the basis of our clinical management. So now that we know that our patient has cystitis, how are we going to treat it? It depends upon the local sensitivity pattern, and in India, E. coli, Klebsiella, and Enterococci have been found to be the most common organisms. And for any antibiotic, we'll have to be certain that the resistance rate is low. The drug should not have cross resistance, and it should be safe to be used on OPD basis. And guidelines from the ICMR DHR group in 2017 had suggested nitrofurantoin, cotrimoxazole, ciproflox as a first-line therapy. However, subsequent studies have shown that the risk of resistance with cotrimoxazole and levofloxacin is nearly 45 to 55% in the Indian scenario, and hence probably nitrofurantoin is now the first-line therapy along with fosfomycin. And as an alternative, augmentin can still be a second-line therapy for these patients, and duration of therapy is somewhere between 3 to 7 days, depending upon the clinical condition. So for this patient, we would want to prescribe nitrofurantoin. The problem is this patient then started having fever, had a culture which was resistant to nitrofurantoin septron, but susceptible to ciproflox. So once the patient is having a fever and upper loin pain, what we are going to suspect for this patient would be a pyelonephritis. So patient would probably have a mild pyelonephritis. So how long would you want to treat the patient with antibiotics? 14 days is what we were conventionally doing for most of our patients, like what Sir has told. But overall, what has been now found is that even 1 week therapy is sufficient for most of the cases of pyelonephritis. Pyelonephritis, the risk is increased, especially in young females with history of prior UTIs and diabetic mellitus. And they are more likely to be hospitalized also. And even if they have renal dysfunction, the risk of mortality is not increased in pyelonephritis. So we don't have to worry if patient develops AKI even with pyelonephritis. For management of pyelonephritis, oral drugs, quinolones are usually preferred. And the ICMR DHR guidelines says that piptaz or piperazine tazobactam or a carbapenem can be used. And they specifically say that if a blood culture is positive for the organism, a carbapenem has to be used. Otherwise, a piperazine and tazobactam combination can also be used. And this they say it to be used for 10 days. This is what Indian guidelines say. With regard to the duration of therapy, we have the wonderful RCT which was done in 2021. And we have a study from JIPMER and also a systematic review which was published a couple of months back. Almost all have told that there is no extra benefit of therapy for 14 days, and even 7 days of therapy is sufficient if patient does not have any red flags. So what are the red flags? So the red flags would be if the patient is unable to take orally, patient has an uncertain diagnosis, has features of sepsis, urinary tract obstruction, is pregnant or has dehydration. Then the patient would require hospitalization and probably would require prolonged therapy. These are nearly the same indications for imaging also. Not all patients would require imaging, only if they have symptoms of obstruction, have some history of genitourinary surgery, polycystic kidneys, neuropathic bladder, and some unusual organisms including TB, fungus, and proteus. Then an imaging has to be done. And this is similar to the reasons for urological evaluation. If there is a male patient with either of these features, presence of hematuria, or with obstructive symptoms, then a urological evaluation also has to be done for the patient. So not all patients require hospitalization, not all patients require imaging, not everyone requires urological evaluation, but we need to understand which are the red flags for us to refer them appropriately. So for this patient, we would obviously give therapy for 7 days. The next patient is a 32-year-old diabetic patient who on a routine visit, you have sent a urine analysis. And in that urine analysis, patient has some pyuria and a culture positivity. So basically, it is an asymptomatic bacteria. So when will this patient be treated? If the patient is pregnant, if the patient is having elective hernia repair in 48 hours, if there's an elective cystoscopy which is planned, or if the patient is a liver transplant recipient, when would you want to treat this patient? Do you want to take it up? Asymptomatic bacteria does not require therapies in most of these situations, and it does not require evaluation in most of these situations. This is because studies have shown that treatment of asymptomatic bacteria, it increases the risk of multi-drug resistant organisms and C. diff, Clostridium difficile also, and there is nearly 8.5 times increased risk. So we treat only if the patient is pregnant or if there is a urological procedure which involves mucosal bleeding, or trauma. So even in a routine cystoscopy, we need not treat asymptomatic bacteriuria. Only if there is bleeding, like if there is a TURP surgery or a cystoscopic biopsy is done, it should be done. With regard to organ transplant recipients, only renal transplant recipients with asymptomatic bacteria may need therapy. We don't have guidelines for the same. So early post-renal transplant we may treat, others we still don't treat, or the guidelines are not certain even in that with case of asymptomatic bacteria. In pregnancy, we always have to treat because the risk of preterm delivery is there. Drugs preferred include oral beta-lactams, fosfomycin, and nitrofurantoin if it is in the first 2 trimesters. Nitrofurantoin has to be avoided in the 3rd trimester due to risk of methemoglobinemia, and Septron has to be avoided for these patients. The next case would be about a case of catheter-associated UTI. I'm not going to the question because the question is basically about the criteria for COTI. So the CDC COTI criteria says that if there is an indwelling catheter for more than 2 days, if there is one organism at least with more than 10 power 5 colony forming units with a clinical feature, then a diagnosis of COTI or a catheter-associated urinary tract infection can be made. And at every instance, whenever we diagnose a catheter-associated UTI, we should reassess if the patient requires a catheter, and whenever possible, we have to remove it. We should regularly reassess if there is a risk of infection, and we should train the patient if at all there is incontinence. With regard to antibiotics which have to be used for COTI, it is based upon the local antibiogram is what IDSA gives, whereas in our institute, we usually prefer piperacillin tazobactam or using a carbapenem for 7 to 14 days. So this patient with a catheter-associated UTI with heart failure, he was treated with IV ceftriaxone based on local practice. But and catheter was removed after he developed a catheter-associated infection, which was a standard practice. But then he developed a severe pain during voiding. And when the prostate examination was done, it was tender and swollen, and a CT scan had shown a heterogeneous appearing prostate, something which is suggestive of an acute prostatitis. So what will be the duration of antibiotics which will give in this patient? So standard we have been speaking about 1 week is enough for pyelonephritis. So what would be for prostatitis? So I can hear a lot of 6 weeks out here. Okay. So overall the risk factors for prostatitis is that patient will have a BPH, has had some catheterization or some manipulation which is done. A history of sexually transmitted disease also increases the risk. And if at all they are sexually active, Neisseria and chlamydia test also has to be done. These are the risk factors for prostatitis overall. And for any febrile UTI in a male, prostatitis has to be ruled out. For an acute prostatitis, quinolones are the first therapy. Usually up to 6 weeks may be required, but most of the patients, they respond within 2 to 4 weeks. If it is a chronic bacterial prostatitis, therapy has to be for minimum of 6 weeks. And for recurrent cases, up to 12 weeks of therapy has to be given. We do not use nitrofurantoin in this case because nitrofurantoin is otherwise the most common antibiotic what we use for a routine cystitis or a UTI. So in this patient, we are treating the patient with prostatitis. We are going to give oral levofloxacin. We are going to discharge the patient. We notice that the patient is on dapagliflozin. So dapagliflozin, would you be recommending the patient? How many of you would want to continue the drug? How many of you would want to stop the drug? Stop. So general thing what we all used to think would be that dapagliflozin has to be stopped. However, dapagliflozin doesn't have to be stopped because there is no data to suggest there is an increased risk of UTI. It only increases the risk of genital mycotic infection and probably Fournier's gangrene. This is probably a very nice chart which I could find out overall that if the patient is having a cystitis or a moderate complicated UTI, then an oral antibiotic therapy can be given. Even if he is hospitalized, we can maintain the SGLT2 inhibitors unless and until it is severe UTI. That means if the patient is having acute kidney injury or has sepsis-like features. And if at all patient still develops a recurrent UTI, then we will have to maintain the SGLT2 inhibitors till it is severe. So only if there is an underlying reason why the patient develops recurrent UTI, SGLT2 inhibitors need not be stopped. They can be continued unless and until it is a very severe episode of UTI. This is what the latest guidelines say. And if at all, there is no use of shifting between various classes. All the types of SGLT2 inhibitors have the same risk. In practice, what we normally practice is that if a patient tends to have a pyelonephritis, we tend to usually stop the SGLT2 inhibitors. For any other cause of UTI, we don't stop. That means the lower urinary tract UTIs or uncomplicated UTIs, we do not stop SGLT2 inhibitors in our routine practice usually nowadays. The next thing would be about a young boy, young baby, 5-year-old boy who has pyuria and a positive nitrite by dipstick. This is for understanding how we have to treat a pediatric UTI. Usually we don't manage the patients, I don't manage them. But overall, if at all a pediatric patient has symptoms of UTI, leukocyte esterase or nitrate is positive, then empirical antibiotics have to be given. If at all they are less than 6 months or if they have risk factors, even if leukocyte esterase and nitrate are negative, then also antibiotics are given till we get a culture report. If the culture is sterile, then we can stop antibiotics. Otherwise, the antibiotics have to be continued for these patients. The symptoms are nearly the same, but in younger age group, irritability, hypothermia, and other symptoms may be predominant as compared to the routine symptoms of urinary tract infections. The next question in a child would be, what is the duration of therapy and when should we repeat the cultures? The duration of therapy is nearly the same. For cystitis, it is 3 to 5 days. For pyelonephritis, it is around 7 to 10 days. It is again with with a beta-lactam is what is usually preferred even in the pediatric age group. So it is quite the same. But one thing which is different is that imaging has to be done for all patients with pediatric UTIs. And a DMSA scan can be done after 4 to 6 months if there is a recurrent UTI in these patients. The last case would be an elderly female patient who has had 3 episodes of cystitis in the last 9 months. Evaluation had shown atrophic vaginitis. Patient otherwise doesn't have any other comorbidities apart from hypertension, has a normal kidney function with a normal urine analysis. So what would be the intervention which you would like for the patient? Long-term antibiotic prophylaxis, vaginal estrogen therapy, cranberry juice supplementation, or no recommendation, because only if there is symptomatic we want to treat. Start vaginal estrogen. Thank you. That's perfect, sir. So overall, the estrogens per se, they tend to maintain the epithelial barrier very well. The lactobacilli numbers are good, because of which urinary tract infection is less. So whenever there is a deficiency of estrogen, the epithelial integrity is lost and the risk of urinary tract infection is going to increase. So secondly, in the postmenopausal females, there is a reduced urinary flow because of increased residual volume. There's an increase in vaginal pH because the way the lactobacilli are there is changed, and the commensal lactobacilli is also lost. And this predisposes the patients to recurrent episodes of urinary tract infections. Can we give oral estrogen therapies? They have been found to prevent UTI. They can prevent ischemic heart disease. They can prevent osteoporosis also. However, the risk of malignancies, endometrial breast malignancies, thromboembolic disorders, and cholestatic liver disease is high. So per se, for recurrent UTI prevention, they are not going to be useful. And they have not been shown to increase the local lactobacilli also. So we don't advise just as a preventive measure for recurrent UTIs. Local estrogen therapy through vaginal rings, pessaries, and vaginal tablets. They can cause only local side effects like vaginal discharge, itching, burning, and some menorrhagia. And studies have shown that they are useful. They are useful even as compared to antibiotic prophylaxis also. So it is now recommended for postmenopausal women with recurrent UTI, and it is useful if the patient is going to have features of atrophic vaginitis. Otherwise, it may not be useful in most other patients also. And apart from this, what has to be advised for this patient are the behavioral measures. Adequate hydration of around 1.5 liters per day to avoid holding urination, about genital hygiene and sexual hygiene. This has to be advised to almost all patients of recurrent UTIs, even in the postmenopausal age group. The other controversial thing or the other common thing what is being used is cranberry. So it is the most known non-antibiotic agent which is used for urinary tract infections. And the reason why it is effective is because of the presence of anthocyanidins. So it has fructose and proanthocyanidins. Fructose tends to inhibit type 1 fibrae, whereas proanthocyanidins inhibits P. fimbriae. So it is usually effective against E. coli, Proteus, and Pseudomonas. And studies have shown that even 240 ml of cranberry juice, it prevented addition of E. coli in around 80% of the cases, and nearly 72 grams of proanthocyanidins is needed for the maximum activity. So the normal cranberry or cranpack tablet which we see, it has 300 milligrams of 300 milligrams of cranberry extract, of which only 20% is proanthocyanidin. That means it will come to only 60 grams. So that is what we should remember when we are dosing cranberry as a prevention for UTIs. And studies, they are not very positive. There are some positive studies, there are some negative studies. But the plus point for cranberry extract is that it is safe. It doesn't have any long-term side effects. So probably we can still try cranberry extracts for this patient also. So because we are seeing about recurrent UTIs, if a patient is going to have 2 episodes within 6 months or 3 episodes within 12 months, it becomes recurrent. And it can either be because of persistence of infection or because of reinfection. And for them, if you are considering antibiotic prophylaxis, it can be a continuous low dose patient-initiated intermittent, a post-intercourse prophylaxis, or some other strategy. So continuous low dose, you can use it for months together or even up to years. Trimethoprim 100 mg, nitrofurantoin 50 mg is what is used. If at all patient has a prior culture, then that antibiotic has to be used. But the problem is, once you stop it, the recurrence rate is high. And if the patient has a recurrence during prophylaxis, then we have to have the culture sensitivity and give that antibiotic and probably continue it as for the prophylaxis. And in the long-term prophylaxis, the risk of multi-drug resistance is going to increase when a low-dose prophylaxis is being done. Second option would be a patient-initiated intermittent therapy. So if the patient has symptoms, has reagent strips at home and is able to check it, then they can take an antibiotic. Usually Septron or nitrofurantoin is preferred, second line being cephalosporins. This reduces the risk of resistance but requires the patients to be more cooperative. Post-intercourse prophylaxis is for females patients who have intercourse as a triggering event. Again, nitrofurantoin and trimethoprim can be used. And one thing which we should remember is that as we are speaking about antibiotics always, there's an increased risk of antibiotic resistance over the years, and we need to look for non-antibiotic alternatives. And a number of ones, like apart from cranberry, like probiotics, intravesical hyaluronic acid, oral immunostimulants, D-mannose, Chinese herbal medicines have been studied, but all are in various stages. We don't have complete data for all. We also have vaccines which have been developed. They are also in phase 2 and phase 3 trials right now. Probably in the future, we may have vaccines for at least patients with recurrent urinary tract infections. So to conclude, UTI is common, diverse, and it requires personalized management. Usually an outpatient-based therapy is sufficient for most of the patients. We relax to decide for imaging, hospitalization, and referrals. And local treatment guidelines have to be followed whenever we are advising antibiotics. Probably with newer diagnostic methods, treatments, and vaccines, the future may be still better for us. Thank you.
Thank you, sir, for a vast topic in the 30 minutes covering.
Cranberry extract. What is the dosage and the duration?
So there is no duration. It can be given for a long period of time. There is no issues with safety. Studies have shown that 72 grams per day is usually effective. So the routine, most of the preparations, they have 300 milligram with 20% proanthocyanidins. So that would be around 60 grams. So 1 BD probably would be a good dose for most of these tablets. And we can give it for months together also.
So for recurrent UTI, you have said you can give nitrofurantoin for 1 year. That is 6 to 12 months.
Low dose continuous prophylaxis.
But the same question I am asking for track free, that's cranberry. So you have to give it for 1 year.
We can continue it as long as we want. We'll never have studies having a duration type 1. We cannot have a study where it is compared with 1 year versus 2 years, 1 year versus 6 months, because we can't have so many patients. So in general, what is told is that 6 to 12 months, if at all the precipitating factor is removed, then you don't have to continue the prophylaxis. If there is no precipitating factor or it cannot be removed, then we can continue it even lifelong also. There are patients of high-grade VUR or bladder bowel dysfunction for whom antibiotic prophylaxis is continued lifelong also.
Thank you.
Cranberry can also be continued probably.
Thank you.
Thank you, Dr. Arun, for your elaborate and all stages of UTI in all age groups and both sexes. As a gynecologist and obstetrician, we had many queries, but you sorted it out. Thank you so much.
Thank you.
For the felicitation ceremony, I would like to invite President AMA Dr. G.B. Rai, Organizing Secretary Dr. Anurag Singh, Secretary AMA Dr. Ashutosh Gupta. I request all the chairperson to please join on the stage along with the speaker.